So it's my pleasure to be here today, and I'd like to introduce our next speaker who has spoken before the County Council a number of times. I'm a huge admirer of him. Dr. Banta-Green, Caleb Banta-Green, is an acting professor at the University of Washington School of Medicine's Addictions, Drug, and Alcohol Institute. His research and study focused primarily on substance abuse disorders involving opioids and stimulants, also on interventions to support recovery and reduce substance-related harms. His dedication to developing interventions that are so needed, but that are needed to be more accessible to all people, that really help to limit barriers to care and enforce the understanding that with treatment, there is hope for recovery. That is so critical. Dr. Banta-Green.
Let's hold this real quick. Okay. Get in here, Doc. Where are you, Doc? All right. Good to see you. Good to see you. Thank you.
Thank you, Deontay. I'm proud of you. I'm very glad to be here with you. I think today flows well into my conversation. I'm going to get into some of the details of how we actually do what we're talking about, because we do know what to do. We just basically need to do it. I will share, just for some context, that I'm also been working with Brad and others on the King County Opiate Task Force since 2016, working with Malika and Sarah and others here on the State Substance Use Recovery Services Advisory Committee. I'm one of the sponsors of the State Opioid Response Plan. So coming at this from a bunch of different perspectives. My background is in public health and social work, and I think that's hopefully kind of manifest in our work, that social work is in many ways sort of asking people what they need and giving it to them. And public health is hopefully about taking it to scale. And that's what we're doing. So I'm going to talk about low barrier service models for opioids and stimulants in community settings. I was struck by Dow Constantine using the phrase low barrier in 2015 when we took an idea to the mayor's office. We used that phrase, and nobody had talked about that. And I think just 3 years later, at a county kind of working group, everybody was starting to talk about low barrier in their services for opioid use disorder. I've never seen something happen so quickly. And it's because people want it and it works. So that's what we do. Pretty importantly, conflict of interest. I have no conflicts of interest to report. I don't take money from pharmaceutical companies. I do have funding from the State Healthcare Authority, as well as the National Institutes of Health and from the Paul G. Allen Family Foundation. So I'm going to talk about why community-based low barrier care. I'm going to talk about the origins of community-based low barrier care for opioid use disorder, sort of an evolution of that. A lot of this is going to hear about how we're building on things over the last 8 years or so, where we're trying things out in King County, evaluating it, testing it, and sort of taking it to the next level. We've been expanding that to stimulant use disorder. I'll talk a little bit about implications. And then what I didn't put on this slide, I'm going to also talk about some things that Representative Davis spoke about around 5536 state law that is, I don't know if it's hanging on by its fingernails, but is in a tenuous state. And where we're trying to go with that work and how that is a next iteration of what we're looking to do. So you've heard some of these things around a persistent treatment gap, and that's definitely true. What we don't talk about is there's also a persistent and huge harm reduction gap. The minority of people with substance use disorder are receiving any treatment, let alone evidence-based treatment. We have been expanding capacity in many different ways. Many in this room have been integral to that with some of the SAMHSA state opioid response dollars. Those can also be used for stimulant use disorder as well. And there's a lot we've learned that's worked and not worked in those processes. I will say what we are seeing is that this can be done anywhere. This can be done across the state. It can be done in a healthcare agency. It can be done in a treatment agency. It can be done in a syringe services program. We can do this, and we can really roll it out in multiple places. And then the data were gone over beautifully by pseudo-epidemiologist Brad Feingood. And what you see in those data is that last year in King County, and very similar data for Washington State, about 80% of opioid death, or excuse me, 80% of overdose deaths involve fentanyl, and about 55% of those involve methamphetamine. They often overlap. they often don't overlap. And there are some reasons, and we'll talk a bit about why our course of treatment will look different. And there will be some intersections and some differences for both opioids and stimulants. So we've just never seen anything grow at the rate we have. I've been an epidemiologist, board certified epidemiologist for over 21 years, and we've just never seen numbers anywhere near this. They're quite stunning, they're quite devastating. Some of the folks here who I've spoken with who are care providers are seeing their staff responding to an overdose a day in some of their facilities, and deaths throughout the year. And it's obviously horrific for those human beings, for their families, but also for the care providers, their communities. Just the toll this is taking is enormous. So I'm going to pause a little bit here to talk about recovery gaps. I used to not particularly talk about recovery. I really talked about treatment. I really talked about harm reduction. And I'm very much of the mindset now that we need to talk about all of these in an integrated way. They should be good friends, and they should know how to work together. The graphs here are a little bit complicated, but the takeaway is basically that recovery from opioid and stimulant use disorders takes significantly longer than for alcohol and cannabis. For alcohol and cannabis, the time to return of recovery capital is about a year. For opioids and stimulants, it's about 3. What we know about substance use disorder is people use substances. And what we know about the process of recovery is many people continue to use substances. And so if we want to support people through that multi-year recovery process, we also need to be providing treatment, and we also need to be providing harm reduction. They are in no way in conflict with each other, despite what we're often told. I think there's just a long history of that I won't go into, but I think we need to look forward and think about how we truly work together to meet the needs of people and that they drive the care. We don't choose, our systems don't care, class, race, those things should not have any relevance in what care people have access to, and ultimately they should have the autonomy to choose their own care. So this is super important. People do want to reduce the chaos, and they often want to reduce their use. We've done multiple research projects. We talked earlier about involving people who use substances in our decision making. We are doing some of that. We need to do better in our work, but one of the ways we do that are through surveys at the syringe service programs across the state. We've done that since 2015 with over 1,000 people at 20 syringe services programs. And I'll share with you some of what those data look like. But people tell us what they want, they tell us what works, and they tell us what doesn't work. And our job is to then put that into effect and change what we're doing. Very importantly, while it's great that emergency departments are trying to start offering more services, that's still not the ideal place for care. You really want to go to the emergency department if you have to go to the emergency department. And initiating chronic disease management for substance use disorder, is not an ideal thing to do in an acute healthcare setting. That just doesn't make sense. So we need to figure out other pathways to do that work. And many folks do not feel welcome in those settings. When we survey people at syringe services programs, we ask them, have you needed healthcare in the last year? And have you not received healthcare, not sought healthcare because of that? A majority, 60% of people, they needed healthcare, they didn't get it. When we ask them why, they say the most common reason is because of how they are treated, the stigma they face around the care that they need. And so they just choose not to go. It's not that they don't want to, it's that they're not welcome there. So these things can overlap, and I want to talk about what is a new, really kind of person-centered, community-based way to deliver this care. In thinking about this healthcare gap, I've worked in treatment settings, I've worked in healthcare settings. Those are great options for care, but it appears for a substance use disorder, they're likely to meet the needs for a minority of people. So we need to think about a third complementary way to do our work. So on the left side, this is a little stereotype here, but the idea of a nice waiting room. I don't know, 1978 called, and here's its waiting room. After 3 appointments over 3 weeks, we may get you started on some treatment medications versus nice to see you, we love you, and let's see if we can get you started on treatment medications today. 2 different approaches. So we talk about this medication first model for opioid use disorder, the essential elements. I also want to share with you, I was somewhat surprised and quite heartened to see on May 9th, the Secretary for SAMHSA put out a letter to colleagues, which is actually a major policy statement by the Substance Abuse Mental Health Services Administration, acknowledging a medication first approach for opioid use disorder. That counseling can be complementary and it can be helpful, but it should never be mandated for folks or preconditioned to getting care. So it's exciting to see federal policy beginning to catch up with what we've been working on for several years. So drop-in visits, short time to medication starts, other substance use is allowed or acknowledged or accepted and discussed initially in an ongoing way. No counseling or support group mandates, it's always offered. And you're doing drug screening to understand what people are using, what substances, and how that's impacting their health, not to punish them. I think the drop-in visits, I just want to take a moment on that. I think is really important. If you think about how long your pizza took, which wasn't too bad, right? That wasn't too bad getting a pizza, but you could get some fentanyl much quicker than that. You could get some fentanyl in that same parking lot much quicker than you got that pizza. And if you are addicted to pizza, extending a strange metaphor, you're going to get whatever quickest. In this instance, it is far easier to get pizza than to get a salad. It's far easier to get fentanyl than it is to get treatment medications. And we need to fix that. We need to fix that. And we can do it, and we are doing it. But it's that idea, right? If I have opioid use disorder, I'm going to use opioids, and I'm going to use the opioids that are the easiest to get. And the opioids that are the easiest to get by far and away is fentanyl. So this is work that the great Brad Feingood and many other wonderful people in this area here today worked on building. We initially came up with the idea in 2015 around a low barrier approach to providing buprenorphine. I think Shayla's here also. Many folks worked on this to get this going by January 2017 at the Downtown Syringe Services Program to begin offering on-site drop-in buprenorphine, one of the two most evidence-based treatment medications for opioid use disorder. And I'm going to share with you a little bit about that, talking with syringe clients about their interest in the program. People come in, the nurse does a brief assessment, and the nurse then works with the prescriber who gets the medication, and they fill that script at the pharmacy. This is really built on a nurse care manager model of care, which is very important. That was a pretty rapid way to expand access to this care model. So a little bit more about this. We did publish the research paper on this. We had really nice findings on this. And this is a strange graph, and I'll explain it. This is really exciting to me, though. This is what I would call a demand curve. This is the metric here, the y-axis is the number of conversations. Not a normal statistic in epidemiology, but a really important one in the real world when you're building and testing a new service. So this is the number of conversations by the first 20 weeks that this new service was rolled out. And the color coding here is based on who initiated the conversation. Blue is a conversation was initiated by syringe service program clients, and red is it was initiated by staff. So in the first week, you see maybe 8 clients asked about the program, and another 20 of the conversations were initiated by staff. By week 5, you flip to now the majority of conversations are being initiated by clients. The word is spread, people like it, they want it, and pretty soon, staff don't even have to talk about it. Clients know about it, they've buzzed about it, they've talked about it with each other, they know and they show up, and by week 12, this was full. And people are often lining up an hour or two before clinic open to come in and get services. So I can't say it enough, if you build it, they will come. This idea that people don't want care, that they don't want good services is incorrect. It is not a true statement. I would also say that we don't need to coerce or mandate people into care. If you build the care that people want, they will show up. Please take a look on our webpage at some things we put out in the last couple of months, both about the evidence base around mandated treatment. It is very weak. And also about the impacts of incarceration on health and trauma, very bad. So please take a look at that. I encourage you to understand that. It's very important around figuring out what your system of care is and where your pressure points are around offering versus forcing people into care. So this quote came, one of the nurses shared this from one of the clients. And they said, I relapsed last week. Every other time I've relapsed while in a program, I kept using because I knew I'd get out. I knew I'd get kicked out, but I knew you wouldn't kick me out, so I didn't keep using. That makes sense? That's called the absence violation effect I learned from my psychologist friends. But basically, it's the flip, right? Person uses, they feel shame, they feel failure, they know they're gonna be viewed as a failure, so they give up. And here is the opposite. They know they're gonna be welcome back. In this instance, the person actually stopped using and came back. So takeaways from this program, really high client demand, 82% of folks who are unstably housed or homeless. Most use multiple substances initially and ongoing. They continue to use a lot of methamphetamine use. And buprenorphine was almost always in the urine drug screens. Went from a minority of people to 96% of people were taking their buprenorphine. And also, very importantly, a significant decrease in illicit opioid use from 90% to less than half of those urine drug screens. It didn't go to zero, and it kept coming back. And also, to be clear, you can be on medications, buprenorphine or methadone, and many people often continue to use opioids and other drugs, and they are still protective of overdose death. We've heard a lot about naloxone. We should. It's vital. It's essential. You should all carry it. You should know how to use it. You should know how to recognize the signs of an overdose. You should look at that brochure that our staff put together in your documents there. But you should also know that naloxone has maybe, at the population level, will reduce mortality by about 5%. That's pretty good bang for your buck for a $100 medication. We should absolutely do that. But medications and people staying on those medications reduces mortality by at least 50%, and it supports recovery. So it's a both and. So we took that work that we did and we expanded this into a community-based medication first study. This is with the funding from the Allen Foundation. We adapted buprenorphine pathways. We added care navigators to this work. Many of them with lived experience. And I'll also say that many of our medical and clinical providers also had lived experience and were in recovery. And that was really vital and important, both to the clients and also for us to learn and make our programs better and more relevant and interesting and accessible to our clients. We did this across Washington State because everybody always say, oh yeah, you can make it work in Seattle, but that's Seattle. So we did it across the state in Kennewick and Walla Walla, Spokane, Centralia. There's been some parallel programs, a separate program in Olympia at the Olympia Butte Clinic, in Tacoma and Seattle. So this has been done all around Washington State. So these programs that we did for this particular study were syringe services programs and or places that did services for folks who are unhoused. And we did extensive ongoing implementation support. I think this is a minor but important note is just like you don't just roll out a new program with like a one-day training and say good luck. This is hard work. The needs of the staff and the clients are always changing. And people need that support and they need that ongoing education to keep doing this work. So we meet with all the different staff, the care navigators, the nurse care managers, the prescribers, the administrators, at least on a monthly basis with our team from the University of Washington to help support them in this work. And sometimes that's clinical support and sometimes it's emotional support. And those are both essential. So I won't bore you. We're like up to here in our nose right now on the data analysis right now. We ended up enrolling over 800 people in this study in the midst of COVID. Also just like for all of you who have continued to provide services during COVID, you are amazing. And I've never seen anybody more prepared to do this. People already were working in the trenches. It was just like, okay, next up. And they just kept doing this work. Even for our study, our enrollment in our study only dipped for about 6 weeks, which is mind-boggling in the midst of this crisis. So a couple preliminary findings. The vast majority of people got buprenorphine the first day. So that is a huge, huge thing right there. We have preliminary data showing a substantial decrease in mortality, much bigger than that 50% that we saw. And then kind of the sniff test that I always look for when rolling out a program, we had multiple administrators who've been around a long time saying, as this program got going, as they started seeing an operation, this is the model of care we've been waiting for. And so that makes me optimistic around the significance of the findings. So we've now taken that work around low barrier buprenorphine for opioid use disorder, and we're working to expand that to also primary and concomitant stimulant use disorder. As I mentioned, many people also are using stimulants. What is interesting around stimulants is that the contrast with opioids, and I don't have all the time to go into it, but what I will say is that when we ask people at syringe services programs, 80% of people using opioids say they want to stop or reduce their use. They're getting a lot of negative effects. It's a negative reinforcer. You go into withdrawal continuously. Getting on medications makes you feel better. Methamphetamine, 50% of people say they want to stop or reduce their use because they're getting a lot of benefit from it. It's enhancing their mood. It's giving them energy. It's an appetite suppressant. And the vigilance that people need who are unhoused is really important. So for methamphetamine, a lot of what you're often trying to get at is underlying trauma and mental health and housing issues. And how do you do that? How do you do that work and that ongoing engagement? And maybe ultimately you'll get to some treatment medications down the line, but those are going to be later. They're going to be in a place where you've taken care of some of those basic needs and they can now start attending to the methamphetamine use. that methamphetamine use for many people is actually allowing them to function. And just to remind folks, methamphetamine is actually a Schedule II drug, not a Schedule I drug. It is a pharmaceutical drug used as an appetite suppressant. And of course, amphetamine drugs are used for ADD and ADHD all the time. These are not unexpected benefits from these substances. So there are obviously severe consequences as well, but we need to recognize the benefits and the harms and have honest conversations with folks if we actually want to engage with them and move forward. So we're building a model in here that is really trying to add more medical care, a lot more mental health care, also addiction treatment, but also harm reduction. And I can't say enough that harm reduction is both a front door and an ongoing service. The idea of having a harm reduction as integral to your work and wherever you are providing care is it provides a giant new front door into your care for everybody. I want something for everybody every day. And if you aren't offering harm reduction services, you're not offering something for everybody. I just told you the proportion of people who want to stop using. It's not everybody, but I want to offer something for everybody. And that means ensuring you're providing harm reduction services. And I say services, and that I don't just mean supplies. I mean people and place who do that work. We need to fund that work. So we're working on this as well in multiple sites. We're trying to show that it works in diverse communities, including rural communities and smaller communities. And we're really trying with this work to not limit the model of care. What we know around methamphetamine use and protracted methamphetamine use is it can impact a person's cognitive functioning for 6, 12, 18 months. And so working with them during that period of time as their health and mental health and cognitive capacity continue to build and get stronger is really important. We need a protracted model of care. This is not a 30-day model of care. This is a long haul where we're with people for the duration. So briefly, just to mention the care components, medications, mental health, medication management for comorbid mental health, drop-in emotional support and brief harm reduction counseling. That's where these care navigators and also mental health staff are so vital. A lot of the decision-making is really critical that people are driving that process. When they feel respected and engaged, they will come back. We are exploring contingency management. We are doing contingency management. It is not a standalone service. And when you offer it in low barrier settings, it is not a hook. What we are finding is contingency management is not to get a person to start care. Once a person's in care and they want to start modifying some behaviors, for a minority of people, it adds some benefit. And again, it's one of these things we should offer. It has some value for some people, but it appears, at least in our work, within this model of low barrier care, it's probably in a minority of people. And that's okay. There might be 5, 6 things that you're offering somebody, and that could be a tool, but we definitely should not be hanging, put all our eggs in the contingency management basket. It's not going to work. Care navigation will work. People will take advantage of it. My colleague Susan Kingston has looked in detail at our care navigation data. Folks were talking to care navigators regularly. They were seeing them 10 times over 6 months on average. That's a lot. Not everybody stayed 6 months. And one of the main things they talked to care navigators about in this model of care that was low barrier and harm reduction oriented, one of the main things they talked to them about was their ongoing drug use. If you can't be honest and talk about your ongoing drug use, then you're wasting everybody's time. When I was working in an addiction treatment clinic a little while ago, like 28 years ago, the last thing my clients would talk to me about is their ongoing drug use. That's the last thing. And so our whole relationship was fraudulent and it was not beneficial. Also need to offer wound care for folks. People are getting wounds for various reasons, whether they're smoking or injecting or using drugs in different ways. And then screening and referrals for all of these things, infectious disease, other types of treatment, and also recovery supports. So I'll just mention, I think having a social work care manager has been very important for us. Again, a lot of implementation support, and we're still exploring the utility of contingency management for stimulant use. There clearly is utility, is clearly a value for some folks. So our next steps, we're trying to figure out how the heck do you pay for this. We're in the midst of lots of conversations on those fronts, both at the state and the federal level. Workforce is a real challenge. I will say, and it was said really beautifully yesterday in a harm reduction training we did, that for care providers using a harm reduction approach, it makes their job easier. It makes their job better. So I'm hopeful that taking a harm reduction approach will actually help with some of the workforce issues we're having. I won't go into details on telehealth and such or get into details on medications, but for opioids, it looks like we're having good utility with treatment medications, long-acting buprenorphine, and we cannot forget about methadone. It's a very, very effective medication, and if people are dosed adequately on it, they can do very well, particularly with fentanyl. So a couple quick things I want to go over. I think I'm actually okay on time. So this is the Substance Use Recovery Services Advisory Committee. This is my first of 4 testimonies that I gave on this. I did not go for the 5th. I don't know if I will go for a 6th. Anyway, here's the first of 4. And you can see what we're talking about. So I was on this committee. There was a treatment subcommittee. And my colleague and friend Alexia Orr from the Okanagan Foundation for Youth Resiliency and Engagement was my co-chair of the treatment subcommittee. I should also mention that there are a couple of folks in here who are on the committee, and there are a couple of other folks who were part of the public who came to those meetings and held people to account and begged us and did their best to force us in positive ways to actually listen to the people whose lives we were trying to make decisions about. So we had a lot of meetings. We had a lot of different people there. I think the perspectives are really important. People lived and living experience, young adults, specialty addiction treatment providers, physical and behavioral health care providers, state agency staff, advocates, public health payers. Representative Davis was, I think, at virtually every meeting. And so these were big, messy meetings. And I actually think we got to some really important places with that work. These recommendations were aimed to address these issues. So the engrossed Senate bill actually mandated us to come up with a plan to provide for the continual, rapid, and widespread access to a comprehensive continuum of care that will be provided to all persons with substance use disorder. That was our mandate. And I think we took a good first stab at it. There are large treatment gaps. There's a Recovery Navigator referral program that people are aware of out there. But those referral options vary greatly in different communities. There's huge geographic variability. A minority of folks are actually accessing care, and then making sure we actually have care that people want. Referring people to the same old thing and being surprised they don't want it, not a surprise. And the urgent public health need, here's just one set of these data, but the increase in the rates of overdose deaths, and again, that's just the tip of the iceberg in terms of the amount of substance use and substance use disorder that's happening to individuals and their families and their communities. So a main recommendation, sort of the next iteration of Medications First, is what we are calling health engagement hubs. This is sitting in front of the legislature right now. It was actually eviscerated and removed on the budget side from the opioid settlement recommendations. The biggest recommendation we made with opioid settlement dollars was for health engagement hubs, and that was entirely removed by the legislature at the last moment. So health engagement hubs are all-in-one locations where people who use drugs can access medical, harm reduction, and social services. And we were trying to address these things around points of intersection, locations, community-based care, and addressing barriers. And this relates to the opioid response plan, which I haven't even talked about. Basically, this is everything coming together. This is trying to make it manifest, it's trying to make it law, and it's trying to get it funded. And it is still plausible. We'll see how next week goes. These are the goal, and I want this to be really clear because this is lost in the current language in the legislation. We said this needs to be first and foremost a model that's offered to syringe service programs to provide. That is now just listed as one of many places. The goal here is this is harm reduction first and foremost. Syringe services programs are the main places we're talking about, and then there are a long list of other types of organizations and facilities that could also offer health engagement hubs. The harm reduction component must be integral, and the services need to address all of these domains. I'm not going to read them because I've already mentioned them on this slide before. So this is also really important. We haven't talked about this today particularly. This is very important. So I was trained in a specialty addiction treatment model of care. And we continue to have funding mechanisms that require people to get a 2 to 3 hour assessment before they can actually initiate care. And those assessments are, for many people, most people I would argue, extremely traumatic. They're generally off topic to the relevant things they need to do to address their care. And they're very, very difficult to access. So the recommendation of the committee is to do away with that as a mandate. If people need and want a long assessment, they can get it. But if they don't, they should be able to get a diagnosis and something called a determination of medical necessity. That's the thing insurers need to pay, and it should not take any longer than 15 minutes. So this was also extremely messy, and I want to be clear, this is not saying these other things can't happen, it's just saying these other things cannot be mandated. Those other things can be beneficial for some people when it is their choice. I'm not going to go into a lot of detail here. This is around opioid treatment program capacity expansion. This has historically been methadone. It also involves buprenorphine. There are new and important ways to deliver this model of care. There still remain gaps in King County for sure. There remain gaps within Seattle for sure, and there certainly remain gaps in Bellevue. But truly in rural communities, it'd be quite desperate where people might have to drive 5 hours to get their medications. So trying to address that. And then a safe supply work group, which oddly enough was the one thing that was funded we did not ask for, but that's great, we'll take it. And this is this idea of understanding that what we're dealing with right now with fentanyl is an unsafe supply. One model of safe supply is buprenorphine. Another model of safe supply is methadone. Those medications don't work for everybody. So the idea here is to create a work group to come together to look at these different scenarios of safe supply, how that might be made. That could be done through a buyer's club who buys illicit drugs, test them, test the purity, and distributes those. That's one model. On the opposite end might be use pharmaceutical substances and you prescribe them. Just like we do methadone, buprenorphine, similar things could be done with other opioid long-acting medications. So that recommendation is out there. So, for that presentation, these are urgent, these were carefully considered, and I believe that these are some of the most impactful things we can do to transform and scale up care, to support recovery, save lives, and improve community safety and well-being. And just to leave you with this, so we know we have persistent gaps in treatment, harm reduction, recovery. We see there's dramatically increasing need. Given the promises we're seeing with these models of care, how can we as a community essentially support these transformative models of care? One of the ways is to want, demand, and beg for them in your communities, not to argue against them. To say to your neighbors, we want this here. The problem is here, people with untreated opioid use disorder use opiates. If you do nothing, they will use fentanyl. If you do something, they will move into safety and stability and recovery and health. With that, I leave you and thank you very much.